Hey everyone, so excited about today's show. I have been waiting for this for months. We are welcoming Dr. Leonardi on the show today. I'm sure you've heard of him, but if not, he is an endometriosis expert. He's an advanced gynecologist, surgeon, ultrasound specialist, all of the things. He's also an assistant professor and an adjunct professor. So, welcome to the show. Thank you so much for being here.
Thank you so much, Melissa, for the invitation. Thanks to all of the listeners for your attention over the course of this podcast while we talk about endometriosis. It's going to be a lot of fun, hopefully very educational as well.
Yeah, we so appreciate you being here. So thank you so much. And, just to start off, how did you get here? What interested you in starting to work with endometriosis, gynecology? How did you land here?
The short story is that I really was very keen to pursue obstetrics and gynecology as a specialty. And in my residency, I fell in love with two somewhat discordant things: surgery and ultrasound. In the world of obstetrics and gynecology, there's a lot of immersion of ultrasound with obstetrics, with patient pregnancies and following pregnancies through imaging. But in the world of gynecology, there wasn't a lot of imaging integrated into it done by the gynecologist. So I fell in love with surgery, advanced surgery, and I fell in love with ultrasound. And I had to figure out how to combine those two. So I went to do a fellowship overseas in Australia, in Sydney, Australia. And the fellowship was very immersed in endometriosis because there are a lot of emerging concepts in imaging for endometriosis and how imaging can play a role in surgery. So when I got there, I had an interest in endo, but it wasn't something that I was obsessed with. And then really, it just happened. I sometimes say, if anybody's ever heard me on a podcast before, the famous quote from Harry Potter, Ollivander, the wand guy, says, "The wand chooses the wizard." And for me, endometriosis, I think, chose me rather than me choosing it. It's a terrible disease. It's a fascinating disease. It's a lifelong disease. It just is such an incredible and terrible simultaneously thing. So I found it fascinating and then really just started to devote my life to it.
Well, I know patients really appreciate you devoting your life to it, and I want to get into some of the things that you're doing. But when I first discovered you, it was when that paper came out in 2020, and I feel like the headline kind of went a little viral, at least in the endometriosis community, where you were saying, we need to treat this like a benign cancer. And I, as a patient, totally agree with that statement. Do you feel like once that paper came out, did you get a lot of was there, I felt like it went a little viral. Did you feel that way too?
Yeah, it totally did. One of the interesting things about research journals now is they start to track how an article responds on social media or in the media. Does it get picked up by media companies? How many people are retweeting it? And so it actually happened to be one of their most engaged articles for that particular journal. So that really demonstrated to me that we spoke about something very relevant to a lot of people because it was gaining a lot of traction. And even now, that article still comes up once in a while because it strikes a chord for all of the people who are living with the disease, but it also strikes a chord for the people who are helping the patients with it, the gynecologists who understand how complex it is, how terrible it is, and how seriously it should be treated.
Yeah, and that's what I felt from that article too, is I think it helped, like you said, in the medical community, but also just for people who have never experienced it. It's something a little bit more that you can understand. Like, this isn't just pain, this is a severe disease. So, speaking of all of that, I know you do a lot of research and you do non invasive ways to help get endo diagnosis. Will you chat with us a little bit about that? Because I do think this is cutting edge new and it's going to really help out with diagnosis.
For sure. The research focus for me and my team is broad because endometriosis does have its claws in so many parts of people's lives. So we really do look at the full spectrum of basic science research, from blood tests and inflammation markers through to imaging, through to the impact of surgery. We're even starting to look at how do knowledge translation tools like videos introduced in the clinic help people on their health journey. So my research is very broad when it comes to endometriosis, but truly the centerpiece of my research focuses on diagnosing the disease and understanding how we can see the disease in non-surgical ways to enhance the patient care. And in many cases, that's going to enhance the surgical care as well. So it's about diagnosing it. Is it present or absent? And it's also about how severe is it? Which organs is it affecting? How severe are the adhesions? What other concurrent diseases do people have? Things like adenomyosis, hemorrhagic cysts, ovarian masses, PCOS. Really refining the diagnosis of a person who's suffering with endo, so that way the treatment algorithm can be as perfect for that person, really an individualized approach. So one of the studies that I've been involved with is the International Deep Endometriosis Analysis Group. This is a large international group looking at diagnostic accuracy of advanced ultrasound techniques for visualizing endometriosis on ultrasound. And we did a pilot study that was published in, I believe it was 2020, just last year, in the journal Ultrasound for Obstetrics and Gynecology, showing these advanced techniques have an incredibly high diagnostic accuracy for picking up deep endometriosis, ovarian endometriosis. And that's really exciting. But there's the third subtype of endometriosis, which is the superficial endometriosis, the smallest subtype, sometimes a millimeter, sometimes less than that, really difficult to diagnose. And I have a lot of research pertaining to that as well, ongoing.
Okay. So how does that differ, for people listening from the normal ultrasounds that probably a lot of us endo patients are used to receiving when, I don't think anything much shows up on them. I'm not a medical professional, except for like cysts is what I feel like is typically what would show up. How does it differ?
You're totally right that the scans that most people have had in their life are very limited and usually don't diagnose endometriosis unless there's an endometrioma, so an endometriosis cyst. And that is why there is such a negative connotation to imaging right now amongst a lot of people who have a lived experience or a living experience. They have not ever had answers from imaging, and their own experience, even though it's not representative of a global experience, it's a real experience. So they have often a kind of a bone to pick with ultrasound. They don't trust it. They haven't had any reason to trust it because they haven't had the right imaging done by the right person. Right. So the simplest way to break it down is that the scans that are done in most ultrasound clinics around the world, particularly in North America, because honestly, we're very behind here compared to Europe and compared to Australia. The basic scan that's done looks at the uterus and the ovaries. Every endometriosis patient knows that endometriosis is a disease outside of the uterus. So if you have an endometrioma, that can sometimes be picked up on these basic scans because the ovaries are assessed. But deep endometriosis, superficial endometriosis, adhesions, all the things that endometriosis does in the majority of cases, they're not even looked for. So if you don't look for it, you don't see it, right? The counter is the advanced scan, which looks for it. It looks for deep endometriosis in the bowel, in the bladder, in and around the ureters, which connect the kidneys to the bladder. We look for endometriosis in the uterosacral ligaments, which is the anatomic location that is the most common location for endometriosis to exist in the body. We look for a sliding sign, which is the movement between the uterus and the bowel. And this is the most common location for severe adhesions to form in an endometriosis patient. So we look for that negative sliding when there's a stuck bowel and stuck uterus to each other. We look for how the ovaries move, because the ovaries, when they are involved with endometriosis, often get stuck to deposits of endometriosis as well. So we're looking for so many more structures on these scans that allow us to see it. From a patient's perspective, it doesn't really feel that different. It's still usually some pictures through the tummy, through the lower abdomen, and pictures taken through the vagina through a transvaginal ultrasound approach. So it kind of feels the same. And that's why it's really important when patients come into my clinic, I explain you might not feel like this is any different than what you've already experienced, but it is tremendously different. We're looking at so many more structures. We're looking for those adhesions. And that information is so valuable because I never want somebody to leave the office not understanding what we're doing, why we're doing it.
And so are you finding by doing this that it's really helping then? Because I know you mentioned with the surgical approach. So that way you know what multidisciplinary teams to bring in. And I feel like a lot of doctors aren't doing this. I want to get into that too, but I just, you're doing it. So it's helping you to understand when you do go in for surgery, if you do, unless there's other treatment options the patient wants, where you're going to go immediately.
Yeah, for sure. I can tell you that, first of all, nothing is perfect in medicine or in life, right? So there have been a very, very few instances where we miss a deposit of endometriosis, and it's usually very high up. So at the level of the appendix where this large bowel and the small bowel transition. But and that results in, if we do a laparoscopy, we're surprised that we didn't see that on the imaging, so we are not necessarily fully prepared to handle that at that moment. I feel bad about it, of course, but I also don't feel so bad about it because diagnostic laparoscopy is still rampant. And most gynecologists are using diagnostic laparoscopy as a means to diagnose advanced endo. So that way, then the patient can get the secondary surgery, the right surgery. But in my hands, that has happened in my 3 years of independent practice, not including my 3 years of fellowship training. It has happened 2 times where we have not seen something high up. And I operate multiple times a week.
Wow.
So I know when there's a bowel nodule and I send the patient for a consultation with colorectal surgery when I diagnose it. If there's bladder involvement, ureter involvement, I send a consultation for urology surgery. And then the patient actually gets fully evaluated by the various surgical services before the surgery and can get really a true plan by all of the different surgical services. So that way there's no intraoperative diagnosis. One of the things that irks me tremendously is the surgeon, and trust me when I say that there are some minimally invasive gynecologic surgeons that have this approach. They say, we're going to go in, and if we find the bowel endometriosis, I'll call my colorectal surgeon who's next door so that they can come in. This is terrible. The patient doesn't know what they're going to wake up with. They need to know, I'm going into surgery, I have bowel endometriosis, and they get to, in an awake state where they can talk to their family, they can talk to their friends, they can talk to their other endometriosis friends that they might have in real life or online, and they can understand, I'm going to make informed consent about doing a bowel resection, or I might not. Some of my patients don't want the bowel to be touched at all because they're very, very fearful of the rare risk of a permanent ileostomy. Mm-hmm. So the point is they get to decide because they know before the surgery. And I give them that power through the diagnosis and through the understanding of the extent of the disease. What's starting to happen, and I'm really excited about this, the long-term effect is still to be seen, but for most of my time so far, I've been scanning primarily my own patients. So I get referred patients, I scan my patients, I operate or not, depending on, again, the patient's preferences. But now I have an ultrasound clinic where I'm scanning people that are not my patients, not the patients I'm managing for endometriosis. So gynecologists from the region, from far in the region, including St. Catharines, which is an hour away, Toronto regions, which are sometimes 2 hours away. People are coming to me because the surgeons, the gynecologists, want to be prepared. So now in all of these regions, we're starting to see surgeons switched on and they're going into surgery prepared. No more of this, we've encountered your bowel endometriosis. We had to abandon your surgery. Now we're going to have to wake you up and do another surgery. It's going to be so much better.
I literally have chills just hearing you talk about that because I really do think that's going to make a huge impact. My broader question is there's not a lot of people doing this ultrasound technique, right? I have a friend actually in Ireland who's on the show often. People will know who listen, but she was considering flying to the UK. I think there's someone in the UK doing it to have
Yeah.
this done because she didn't want to have another surgery. So, are there a lot? How many do you know how many people are doing it? I know you're part of a group.
Hmm.
Is it still very limited? And could people from the States come get an ultrasound scan with you and then take that back to their doctor? Or
Yeah. So the unfortunate reality in North America is that it's still very rare. There are pockets of regions in Canada and in the US where people are doing advanced imaging for endometriosis. In my province, really, I'm the one that's doing the most comprehensive and detailed advanced imaging, though in Ottawa and in Toronto, there are individuals who are starting to introduce concepts of it. So it's exciting because it's starting to snowball and we're starting to see this introduction. But maybe it's a bit egotistical. I'm the one that spent 3 years of my life mastering specifically ultrasound for endometriosis and surgery for endometriosis. So I have a very systematic approach to it. To answer your question about can people come to me from anywhere? Yes, they can actually. The uniqueness of my ultrasound clinic now is that it's not a very involved process because my actual clinic is in the hospital where I manage patients. My ultrasound clinic is not in the hospital. So people from Buffalo or Detroit or honestly from anywhere can come, and they would of course have to pay out of pocket because they're not um, covered by the Ontario Health Insurance Plan, like the patients who are from Ontario, my province. But that they could choose to do that. And if it means that they avoid two surgeries, that would probably be a cost savings in the end anyway for themselves, plus a risk savings in that you don't have to have somebody cut into your body more than one time. So, yes, absolutely. In the States, there are a few places that are, I would say, really getting to that point. There's an amazing gynecologic ultrasound specialist in Tampa, Dr. Lori Hochberg. Dr. Yvette Grossman, she's in Boston. She's doing amazing work as well. There are a few other regions where people are dabbling as well. Dr. Joel Barkley in Phoenix, Dr. Scott Young also in Phoenix. So there are individuals in the States that are doing good work. So hopefully it means that more and more will continue to do it and learn from those individuals, from me, and will propagate these skills.
well, I mean, just thank you for doing this and spending for, I know you said seems egotistical, but you put the time and effort into this. And as a patient, again, I think this is a huge shift. There hasn't been much change in diagnostic tools for endometriosis in what, 100 years or something, I don't know the number. So that's really great. How do you feel about, I know a lot of people get MRIs,
Mm-hmm.
and how do you like, what are the differences? I don't want to sit on this topic too long, but like I know people get MRIs and then it'll say that they don't have endo, then they have surgery and they have endo, or sometimes it will be detected on an MRI. Do you still think the ultrasound, sounds like yes, but is a better way to go if someone's
The
debating?
The truth is, it's less about the imaging type, it's more about who's behind the imaging. So when it comes to ultrasound, you can have an ultrasound done by a sonographer or a radiologist who's reading it, but if they have, it could be even called an advanced ultrasound. But if they don't have the expertise in knowing how to find, for example, a uterosacral ligament nodule, then it's not going to be properly reported. It could be a false positive, it could be a false negative, right? The same concept exists with MRI. And I see it all the time because in North America, MRI seems to be this test that people consider to be more advanced, more enhanced visualization of the pelvis. But if the radiologist reporting it doesn't know how to look at endometriosis, then it's not more enhanced. Just because the machine sounds more fancy and it costs more money doesn't mean it's better. That
Right.
said, one of the radiologists that I work with at Hamilton Health Sciences at McMaster University, Dr. Al Arnaout, she is a wizard when it comes to MRI. And I can guarantee that my ultrasound report is going to perfectly match her MRI report. We were very proud because she and I, along with several other Canadian radiologists, have just published the first ever practice statement from a radiology organization, the Canadian Association of Radiologists, have just published a practice statement on ultrasound for endometriosis. And very soon there's going to be a practice statement on MRI for endometriosis as well. This is coming in the US too. I think that there are some groups, the Society of Abdominal Radiologists, I believe, are working on a practice statement as well for ultrasound and MRI, which means that expertise is going to be coming. The technology is there, the machines, they exist, but the expertise, that's what needs to be enhanced.
Thank you for
There's a
explaining
lot of
that. Yeah. Go
To
ahead.
interrupt. There's a lot of dialogue online in some of the Facebook groups for endometriosis about you just need to find an endometriosis surgeon, right? You need to make sure the person who's going to operate on you is the right person. They're well trained. What I'm really hoping to see is that dialogue starts to exist for imaging as well. If you have an imaging test by somebody who's a non-expert, well, you know what the result is going to be. It's usually going to be an inadequate, probably inaccurate result. But if you have imaging done by somebody who is well trained, who is considered an expert. How you define expert is always a little bit questionable, but I'm a self-proclaimed expert. I think I have a lot of publications behind me to support it now and a lot of good accuracy in my actual clinical practice. But you know what I mean? If we start to see that dialogue around finding the right imaging specialist, that'll allow for the patient's process to be just better overall. Right imaging, right surgery, you're going to be golden.
I
As
think
golden.
that's, yeah, I mean, I think that's really helpful. But you also bring up a really good point is some people, don't have access to care for surgery. They can't get surgery, especially here in the US, where it's very challenging, especially if you don't have healthcare. But then also just all of the, like, how do there's patients that might be listening for the first time that are just like, oh my gosh, I'm so overwhelmed. I don't even know where to start to find a doctor. And that's still something that I think is a problem because most people are just either going to their family doctor or their normal OBGYN. So for someone who's maybe listening to this and just starting off on their journey, I mean, my advice to them is always like, do your research, find local patients, talk to people. But what are you seeing, or what advice can you give after so many years of seeing patients on how maybe people can cut down that timeline to finding the right people?
It's really tough because you are restricted by your geography. You're sometimes restricted by finances, let's be honest.
Yeah.
Different health systems are going to permit or restrict certain types of healthcare. So there's a lot of obstacles in it. But as you've said, education is really key. So getting connected to the local groups, getting connected to even larger scale groups can allow you to learn a little bit about who might be considered an expert, even though that is still a very controversial domain of how you classify an expert. Truthfully, anybody who is certified by ACOG, the American Congress in OBGYN, or the similar Canadian SOGC, the Royal College, where everybody is certified. But there's no specific certification in endometriosis. There's no criteria that are required for that label. So you just kind of have to have word of mouth, I would say, at this point,
Yeah.
and advocate to get to that right person. The challenges become eventually those individuals are overwhelmed by the volume. And in my practice, I've had to now for the second time shut down referral processes because this is in my clinical practice where I actually manage endometriosis patients because I'm booking into 2025. This is when my first consultation with a patient can be based on the demand. Part of it is I'm on some of these websites. My name is listed. People learn about me. People learn about me through podcasts or social media. So I get referrals from far and wide. And at some point I have to say no, because what am I going to do? Book people into the year 2026 or 2 years from now? They can't wait that long. They're struggling, right?
Yeah.
So it is tough because there's a limited number of us who are doing this. And so the thing that I think patients can also do is to advocate to their local health administration in their hospital regions, even to their members of parliament or government.
Mhm.
There's an organization called Endo Act Canada, and Endo Act Canada has actually prepared a wonderful toolkit for endometriosis patients to reach out to their member of parliament for their region. So that way, a person who is suffering with the disease can write to them. They don't have to know how to write, it's all prepared. And they can say, this is an important topic. You need to focus on this at the level of government because we need more resources, more attention, more money, all that stuff.
Yeah.
Hopefully that exists in some ways in the US as well with some of the organizations that are doing advocacy work.
Yeah. Yeah. And you brought up management. Are there things that you like either post surgery, pre, post, if people don't want to have surgery? Have you found any management tools that you're liking or that are successful that patients may not know about or want to hear about?
Well, regardless of surgery, endometriosis is a full body disease, and it really does require a full body approach to the disease. We all know that it affects the symptoms in the bowel, it affects the bladder, it can affect the mood, energy levels. So it is not something that should ever have a singular treatment option. Of course, we all have heard about the patient who had surgery and then their life was revolutionized. They felt perfect and they went on with their life. I think that's a small minority of endometriosis patients. It's not the representation that we actually should be seeing in social media and in media because it's not reality. It is a full body, full life disease. And many endometriosis patients have concurrent diseases like adenomyosis or ovarian cysts, PCOS, IBS, right? So I actually always implement what I call a holistic multimodal approach. And so, aside from surgery and medications, which is really my traditional training as a doctor, I discuss things like pelvic floor physiotherapy with patients, osteopathy, acupuncture, massage therapy in the physical therapy domain. In the more mental health domain, I talk about pain reprocessing therapy, which is a way that you can retrain the brain to decrease the heightened state that it often exists in when people have a chronic pain condition. We talk about mindfulness and breathing. Some of those things are actually learned through the physical therapy processes, like working with a pelvic floor physiotherapist who takes a biopsychosocial approach. I talk with people about dietary therapies, and I try as best as possible to get my patients to work with registered dietitians to focus on what are things that are triggering and what are things that are beneficial to your pelvic health in general. We talk sometimes about things like cannabis, even, or chronic pain clinic management, where people get injections of anesthetic and steroids. So it's really quite a diverse and multidisciplinary approach to the disease.
Yeah.
I think that those things need to start early and probably need to persist through. So, one of the things that I've done for my patients who are referred to me who have an appointment, let's say in November 2024, right now for listeners, it's April 2023. I usually say there are things that you can start now, and here's a link that gives you education and gives you strategies that you can implement now. The link is a link tree. It also includes links on how to find a physiotherapist, how to find a dietitian, where to do pain reprocessing therapy, because I can't do a consult with them tomorrow. It's going to be in November. So at the very least, I can provide people some education and some tools that they can start now.
This is the most refreshing thing I've heard in years. So thank you. I mean, that's just incredible. That's what all doctors should be doing for patients who are waiting. And everyone, I feel like treats patients just so separately. Not everyone, but a lot of doctors like, oh, you need to go to this one. And it's very overwhelming for the patient. So the fact that you say you like this holistic approach, which I totally agree with, and took me years to kind of discover myself, like, oh, I should be doing acupuncture, or I need to change my diet. But it is a whole body disease. And I know for people who are listening, it is very overwhelming. And one thing that I always tell patients too is take it one step at a time. You don't need to make all of these changes on the first day. You can ease into these things and see how you feel until you can get an appointment and
Yeah,
can have
absolutely.
surgery.
It's
So,
it sometimes is like a full-time job for people who
yeah.
have endometriosis associated chronic pain. It is something that really does require effort. In the world of chronic pain literature, one of the things that I've learned is that people need to have a lot of self-compassion and have focused time for themselves. I explain to some of my patients that this is a physical injury that's happening. It's an inflammatory process, but it's invisible. And so, because it's invisible, it's hard for the person who's suffering, but also the world around them to actually consider it important compared to, let's say, you get into a car crash and you break a limb and you have a cast. You're not going to be doing the same type of work. You're not going to be having the same type of household responsibilities. You actually might have to go to do rehabilitation with a physiotherapist for 2 hours every day. And the same mentality should exist for endo patients. We should have this ability to spend time on healing the body through active therapies that need to happen even though it's invisible, right? We have to overcome this. I'm just going to push through. I'm going to do what I need to do. No, you actually do need to maybe go find space in the basement or in a room in your house and focus on your exercises rather than dealing with all of the other responsibilities that happen in your life. I do think it's incredibly hard though because this disease affects people in their prime, in their young adulthood. And what 20-year-old, when they get diagnosed with endo, wants to be diagnosed with a chronic, incurable, full body disease that's going to take a lot of time and effort? So I get the desire amongst patients to have the what I call the quick fix, the magic bullet surgery. I get it, and I wish that that was the reality, but it's not. And so I try my best to educate people early on the journey as possible so that they get it. But it does take sometimes a few visits before that insight comes because who wants to accept that they're going to have their life is different now and they have to do all these really hard things forever.
Yeah. It's really challenging. And I think also it's challenging, yes, that it's invisible, but just also the lack of awareness. I mean, there's so many other illnesses that I think society understands as a whole, right? Like diabetes or something like that. When you know someone has that, okay, we need to make sure you get your sugar. Where this, for so many years, and I think it's a lot better now, but was just it's in your head, you're making it up. So it's just even the patient, I need to push through. This is just my life and I have to do it. And I think what you're saying is so refreshing, but we still have to work on that awareness piece, even in the medical community and society and public. And that was what I think will really help to change and shift that too, where patients can feel more heard because they're not. And to your point, when I first had my first surgery, I had no idea this was a chronic illness. I wasn't told that. It took me years to understand, like, wait, this is something that I am going to have to deal with for the rest of my life. I had no idea. It wasn't told to me and I didn't understand it. And I don't know, back that was in the earlier 2000s. There just wasn't as much information online like there is now. So how do we help like in medical school or just getting more awareness to the physicians?
Honestly, it's a huge challenge. It is really a huge challenge. I think one of the solutions is outreach as much as possible and visibility as much as possible. So even though it's interesting, I have a big social media presence in Canada, there's no privatization of healthcare. A big social media presence, unlike maybe some American surgeons, doesn't allow me to charge more money for surgery. I never charge any money for surgery because it's all publicly funded.
Right.
And having more referrals doesn't help me because it leads to a longer wait time. But nonetheless, the goal for me is a bit of visibility for my patients, but also to have a voice for them as well in the hospital culture that I'm working in. Politically, I've connected to several politicians locally because I have a voice through social media. So I think outreach in whatever avenue you can do is good, whether that's you as an individual reaching out to your health locally, your healthcare system locally, your politicians, that's valuable. I think patients have driven a lot of education for their doctors as well, even though they shouldn't have to. The reality is that they are doing that. So patients will go to their GP and they'll say, I really need to go to see an endometriosis specialist. And their GP may be like, what is that? Who is an endometriosis specialist? Does that even exist? So they're actually educating their primary care providers about the health journey with endometriosis and who's switched on, who's equipped to do it. I think outreach is the best way that we can achieve that now. And then research. Research becomes published, research becomes credible. Research is how you make arguments to politicians, to health administrators. Saying something is valuable, but having tangible, peer reviewed, published literature is also very valuable. So that's one of the reasons why I spend a lot of my time doing research because it's a form of credibility.
Is there any other research coming up that you're seeing or that you're starting to get excited about
There's a
in
lot
the
of
endo
very
space?
exciting research. Yeah, there totally is. Very exciting in literally a week and a half. The World Congress on Endometriosis will be happening, and it's being hosted in Edinburgh, Scotland, over the first week of May. So the world will be coming together to present a lot of very exciting research there. One of the things that I will be presenting on, this is work that was done in my former life when I was living in Sydney doing my fellowship and PhD, but it's still persisting this type of research into the microbiome of endometriosis patients, the microbiome of the bowel system, the saliva, the vagina. The research that we'll be presenting is a portion of the study, but we've even been looking at the microbiome of endometriosis lesions themselves. So microbiome, I think, is a very exciting area. It ties into the concept of inflammation, which is a very prevalent concept at the World Congress as well. The other exciting area of research is really on the nervous system and how the nervous system changes in patients with endometriosis, leading to chronic pain. So, how does the brain change? How do the nerves in the pelvis change? And I think that drives a lot of the experiences that endometriosis patients have. It, of course, is all stimulated and triggered by the presence of the disease itself. But when you remove the disease and the nervous system is still left untreated, symptoms might persist. So we really need to understand how endometriosis affects the nervous system so we can understand, first of all, how do we prevent it from doing that? But if it has done that, how do we actually undo it?
Yeah.
Those are a couple of very exciting areas.
I'm excited to learn more about those as well. Well, before we wrap up, is there anything else you want to add?
Uh, I would like to inform the listeners of the ultrasound clinic that I mentioned earlier. It's called SUGO, SUGO, and that stands for Specialized Ultrasound in Gynecology and Obstetrics. There's relevance to the name. First of all, I want to point out that the G comes before the O. In the world of OBGYN, the O always comes before the G. The obstetrics seems to be the priority for most health systems. People really care a lot about pregnancy, and people care a little bit less about when women are not pregnant or patients who have uteruses when they're not pregnant. So I really do think that the G needs to be prioritized. So I put it before the O for a reason. And sugo in Italian means sauce, and I'm Italian. So it sheds a little bit of light on my heritage. My grandparents all immigrated to Canada, so it's a little token of respect to them. Sugo is a place that, like I said, Canadians can visit and Americans can visit. if Americans are interested in looking at where it is, the referral form for it, sugoclinic.com is the website. And you can reach out to the clinic and find out if you can make an appointment for an endometriosis ultrasound.
Wonderful. And I know you said you're very active on social media. I do follow you there, but for people who want to follow you or find you, how can they find you?
On Instagram, the handle is Dr. Mathew Leonardi, Mathew with one T, Mathew, Leonardi, Leonardi. On Twitter, it's just Mathew Leonardi. And I do post a lot of my lectures that I do for conferences and webinars to my YouTube channel. So if you simply search my name, Mathew Leonardi, you can either subscribe or not, and you can watch any of the videos that I've posted there that talk about diagnosing endometriosis, the importance of diagnosis, and I'm going to try my best to continue to put forth some of that content so that way it's free access for all people who are living with or potentially living with endo. If they're wondering, they might get some insight into the mechanics of the disease, how to diagnose it. It can be a valuable way for patients to learn more.
This is one of the most inspiring conversations around this disease I've had, and all the work you've done. And I'm not just saying that because you're on the podcast. I really appreciate your empathy and care and compassion and motivation to help people with this disease. It's very clear to me how passionate you are about helping. And from myself and the community, I'm just so grateful and so thankful for everything that you've done. And thank you for coming on and chatting with us. And as more comes around, we'll try and get you back on. But thank you very much for being here today and chatting with us.
Of course. Thank you, Melissa, for the invitation. Thank you for your passion as well. You're doing amazing work by bringing important concepts forward to large audiences. So keep up that great work. Audience, you keep up all the great work you're doing, because I know everybody who is suffering with endo or gynecologic issues, you're your own advocate. You're advocates for people in your life. Keep it up. And what we will see in our lifetime is significant improvements. I'm incredibly optimistic about the direction that things are heading for gynecologic health, but we got to keep working together to get to that point.
Absolutely. Thank you so much.
Take care.